Well, χαιρετισμούς πολλούς από τη Νέα Υόρκη. Λυπάμαι που για οικογενειακούς λόγους δεν μπορώ να βρίσκομαι μαζί σας σε αυτό το φετινό συνέδριο. Πολλές ευχές και πολλά συγχαρητήρια για μια ακόμη χρονιά εξαιρετικής παρουσίας στον ελλαδικό, πανελλήνιο αλλά και ευρωπαϊκό χώρο της Νοτιοανατολικής Ευρώπης για αυτό το συνεδριό σας. Λόγω των εξελίξεων της τελευταίας χρονιάς είπα να διαλέξω το θέμα της εμφύτευσης βαλβίδος, αορτικής βαλβίδος σε γυναίκες και ασθενείς με μικρούς δακτυλίους. So let's switch in English. So my topic this year is going to be TAVI in women and small annuli, given the very important data that we have published over the last several months since your previous Congress a year ago. Let's see what we know, first of all. Women in general don't seem to be doing that well after TAVI, at least compared to the expected longevity that you can see there with black line, and you can see the men in blue. They seem to be approaching that a bit more so than women. And the disease itself, the pathology, the anatomy, the pathological anatomy, one can say, is very different. Women seem to have more fibrotic valves, still stenotic, and men have more calcific. So that may lead actually to some underdiagnosis or under selection or under treatment for TAVI, just because it's not the classic supercalcific presentation. At the same time, the hearts themselves may be somewhat smaller in women, and the concentric hypertrophy may be more accentuated. These are the differences that you can see in ascending aorta, sinus, annulus, and LVOT. So although you can see the sinus and the aorta, they're sort of approaching each other, the annulus and the LVOT seem to be smaller, significantly smaller. Let's keep that in mind. In general, when we want to study something, before a very large study, we tend to do some secondary analysis or a meta-analysis of small studies. And as you see here, what's depicted is that in a meta-analysis of about 4,000 patients, the women seem to be doing quite a bit. Why would that be, though? Let's look a little bit further into that. And that could be also any differences between TAVR valves. A first trial, a small trial, pilot study, 150 patients or so. No differences in hemodynamics, patient prosthesis mismatch or clinical outcomes between TAVR and SAVR, TAVR in blue, SAVR in red, and you can see the gradients and the valve areas depicted in the screen. This is a Viva investigators from Canada. No major difference. However, there was a very interesting study from Europe, European study, the RIA study presented in European Society of Cardiology last fall. And it was very interesting, was double the size or triple the size of the Viva. There were about 250 per group. And they used only one valve, the SAPIEN 3 valve Ultra, or the SAPIEN 3 Ultra valve. And we had a composite endpoint of all-cause mortality, stroke, or repeat hospitalization within 1 year. And you can see that very clearly that TAVI was overwhelmingly better than surgery in women. And again, as I said, women, in essence, means people with small annuli for the differences I explained to you before. And this difference is mostly due to the death and the rehospitalization. We're not really talking about difference in stroke there, and they're both about 3%. Regarding the PVL, maybe a mild PVL might have been a little bit higher with the TAVI at 30 days in 1 year, but the PPM, the patient prosthesis mismatch, was very similar. Severe PPM, no difference, and moderate PPM also not so different. not small size though, moderate ppm, about 17% of these cases. So could we focus and do something about those ppm, and what does it mean really? Should we be focusing any attention, paying any attention? And that's where we come to different types of valves. There's some valves at the supraannular position, they may have lower gradients, may allow you, if you want, to place a one size higher valve, as we practically say sometimes. So the patient processes mismatch, first of all, is associated with female sex, small annuli, and small prosthetic valve size. Obviously, the three of them are confluent and interrelated with each other, because the annulus is small, you definitely want the small valve. You do a good job because you don't want to rupture the annulus and place in the big valve. So they may, in the end of the day, it just reflects again the anatomic differences of women that I showed you in the very initial slide with the anatomy of the ascending aorta, the sinuses, the valve, and the valve annulus and the LVOT. Remember that great slide? So it's all very, very important. Severe patient prosthesis mismatch after TAVI is associated with mortality in general, and probably the same happens actually, as we know, with the SAVR. I'm going to show the data a little bit different. This is different studies, as you can see, different times, different investigators. Everywhere the message seems to be the same. This is the association of structural valve deterioration in the Australian Echo Registry, and we can see the differences of mortality even at 5 years, without no difference between SAVR and TAVR. Again, I may point that out, that although sometimes we have more data because there's more research happening with the TAVI valves, this doesn't mean this phenomena and these complications are particular to the TAVI valves. They're just understudied in the SAVI valves, some of them. And when you study both of them, you can see they suffer from the same complications, same issues, smaller size, higher ppm, greater concerns later on. So the intra-annular valve in the preliminary analysis was indicated to be perhaps a risk for ppm. Of course, it's a hypothesis generating, and it generated a hypothesis in the SMART trial that was presented in 2024, one of the highlights of last year, with patients with symptomatic severe AS and small aortic annulus, exactly as depicted here, stratified by a site and sex, about 350 patients per group in the self-expanding or balloon expandable valve, essentially the supraannular self-expanding or the intraannular balloon expandable valve. These are the two valves they compared, and overall, the mortality disabled stroke or hospitalization, there was not much difference at 1 year. However, the prosthetic valve dysfunction, as defined primarily in association with patient prosthesis mismatch, seems to be higher with the intraannular balloon expandable valve and lower with the self-expanding valve. So due to the gradients and the orifice areas and all the various things, all of them essentially speak to each other because the definition includes either one or the other parameter. In general, there were low gradients of sizable gradients with the self-expandable valve. What does this mean? Well, maybe superior, but what does it mean clinically? It may mean something, particularly women. You can see there seems to be a little bit of a trend happening in the balloon expandable valve, greater events, clinical events at 1 year. And again, the same picture in the women sub-analysis. Most importantly, we have the 2-year data. So far, nothing budges as far as the clinical events. It was presented in a conference just a couple of months ago at the New Washington, D.C. And you can all the events independent of each other and no difference in any of the events. Pacemaker implant always a little bit higher with the self-expandable valves. That's actually expected. Otherwise, the stroke and the prosthetic valve thrombosis is really small. It happened 2% perhaps in the expandable valve. At 2 years, happens up to 4.5%. Still a rare event. Nonetheless, seems to be less so in the self-expandable supraannular valve, 1% or less of that. Most of them are subclinical though, so essentially it's a CT angiographic finding in patients with high gradients. So the high gradients translate to some clots in the valve sometimes. And again, this is, I would say, hemodynamic and imaging finding and phenomenon. These are the patient prosthesis mismatch that you can see as adjudicated by the committees, but again, I would say it's mostly, I would say, subclinical, as I explained to you before. And again, it's a concerning finding. We're going to see in later follow-up in a few years more, what does it mean as far as perhaps the duration of the valve, which is the, I think, the holy grail of research of TAVI this decade. So my take-home messages, and many thanks for paying attention, a brief lecture. We have to be aware for the risk of adverse hemodynamics, severe patient prosthesis mismatch, and high gradients associated with TAVI in women. It's very important, as well as, I would say, the same with a small annulus. Although 90% of the people with small annulus are women, so only a small portion of men really fall into this category. TAVI may be superior to SAVR in women with severe aortic stenosis and small aortic annulus, as depicted in the European multi-center prospective randomized trial RIA last year. And when choosing a TAVR prosthesis, there's active research as a sub-analysis of the secondary analysis of the SMART trial, focusing into the increased gradients with the intra-annular valves versus the lower gradients of the supra-annular valves, and we continue to track what this means as far as clinical events and as far as valve durability. Thank you so much for your attention. Congratulations for your Congress, and I hope to join you on site next year. So long from you.
Yeah, this is a big discussion about the issue George presented to us now. We understand and we know from studies that in small annuline in women, the self-expandable valve offer better hemodynamics, but we don't know. But we know that there is no difference in the clinical outcome so far. So you can say that if I get a balloon expandable valve, I have a mean gradient of 15, but patients are not coming to us saying, doctor, I have a mean gradient of 15, I have a problem. So it's important to follow up these studies to see the long-term results, but so far I don't think they have a big clinical impact, and the better hemodynamic is something that we take into account in the algorithm of device selection decisions. So it's a plus towards these valves, but this is not the only one. So I think it's now time to move on to Professor Vardas.